For coming with us today. My name is Lori Asmus. I'm the manager of integrative services at Hospice of Cincinnati, which includes our volunteer and holistic programs and our end-of-life doula programs. The class that we're doing today is part of our end-of-life doula certification. There are 4 classes that are required to take for this. We are excited to have many of our volunteers seeking certification this year who will watch the class and be able to extend their skill set, talents, and knowledge with the additional education. I just want to share with you that our hospice volunteers, we love you. You are amazing. You are great supporters of the team. You are integral to our team, and we want to learn from you as much as you learn from us. So if you have any feedback after the session, please send it to to me or to our HOC volunteers at trihealth.com. You can also send any questions or need for follow-up information. Today we are discussing Hospice and Palliative Care 101. We're going to do this class in just an hour. So we're very excited about that. The realm of hospice care is increasing and expanding, and so is palliative care. And I'm pleased to welcome Carol Quackenbush. She's a friend, she's a colleague, and she's someone I enjoy doing a lot of projects with, and she's top in her field. So welcome, Carol. You're going to go ahead and introduce yourself, and I'm going to launch the presentation.
I appreciate that. Good morning. As Lori said, I'm Carol Quackenbush. I am the Education and Marketing Specialist here at HOC Navigators. I've been with TriHealth now for about 3 years, but have been doing hospice care since the 1900s. So I've been a nurse for quite some time, and things have changed, but a lot of things have remained the same. And the volunteer department is certainly a huge integral part of what we do. So I thank all of you for your involvement. And Lori will put some things in the chat about questions as I move forward with the presentation. And you can certainly email questions at a later date if things pop up for those of you that are watching this at a later time. So I'm just going to go ahead and get started. Are we okay, Lori?
Yeah, can you see everybody see the PowerPoint now?
I sure can.
Okay, let me change the, are you able to see that PowerPoint? Okay, let's see, content only. How about that? Does that look, are you able to see it, Carol, or not?
I can, yes.
Okay,
great. Time, yeah.
Then that means everybody else can too. So go right ahead and launch into it.
Great. And then I'm just going to say next when you need to proceed.
Okay.
So thank you, Lori. Like I said, I'm with Hospice of Cincinnati, and a lot of times you'll hear HOC Navigators utilized as well. And HOC Navigators is the name we utilize because of our involvement, not just in hospice. We obviously do palliative care, and we have advanced illness programs. And obviously we do hospice care, and we have wonderful grief services as well. So again, that's why you'll also see the term HOC Navigators used. Okay, next. We'll start with palliative care. And palliative care is defined as medical care focused on the relief of symptoms of stress and serious illness. The goal of palliative care is obviously to improve the quality of life. And unlike hospice care, which we'll talk about in a few minutes, with palliative care, patients or individuals can continue to pursue treatment. Palliative care does not necessarily mean end of life care. It certainly is broaching that, but with palliative care, patients can continue to receive treatment such as chemotherapy, radiation, or whatever is appropriate for the disease process that they have. Okay, next. The palliative care approach is a team approach. There are nurse practitioners, nurse care coordinators, a social worker, office and administrative staff, obviously, and a palliative care physician oversight. But typically it's the nurse practitioner going into the home or long-term care facility to see the patient once they've been referred to palliative care. Infrequently, palliative care is a step before hospice care for many individuals. Okay. With Hospice of Cincinnati, our palliative care program is called Palliacare, which can be a mouthful sometimes. In the palliative care team, the main person that's going into the home is the nurse practitioner, and she provides the in-home services to the patients, but she also keeps their primary and specialty providers up to date as well. And the goal of palliative care is that extra layer of support to hopefully help decrease the amount of times that patients and their families are having to go to a doctor's office, because the nurse practitioner can communicate directly to the patient's physician and even help with ordering medications or treatments to help with the patient's comfort level. But again, patients continue seeing their primary physician and specialty providers once they're enrolled in palliative care. Again, it's that extra layer. The visit frequency is determined by the practitioner and is patient specific. So it's not a blanket mode of treatment for every single person. It's individual to the patient that they're caring for. And there is that 24 hours a day, 7 days a week phone triage support, because invariably questions or issues are going to come up after the nurse has been in the patient's home. So if there is a question after hours or a change, the family can certainly call the palliative care triage line. And if the question cannot be answered, the triage nurse can direct the patient and family what they need to do, whether it's to go to the emergency room or make an in-person visit the following day. And a doctor order is required for a palliative care consult. Okay, Lori,
Okay. Go back
was there a
here.
question?
Nope,
Okay,
just, there you go.
thank you. One of the great things that palliative care provides also are the goals of care discussions. And the conversations certainly start with a understanding of the patient's values in making sure that their family members also understand. It's introducing the medical perspective as a foundation for goal setting and next steps. Many times people have never really thought about what their goals of care are. So when there is an actual practitioner in their home and the patient and family can understand how this disease is progressing, it will allow the patient and family to have a discussion and for the patient to be able to relay what their wishes are. Because again, a lot of times people haven't had these discussions, nor do they even realize themselves how they truly feel until they're asked to reflect. So it's a great way to get these discussions started under a palliative care. And the palliative care nurse can make treatment recommendations based upon what the patient wants. And a lot of times, most patients' goals of care are avoiding going to the hospital. And having that extra layer of care with palliative care, coordinating with the physician, can certainly help decrease the need to go to the hospital or the ER.
Yeah, so goals of care was kind of a term that I wasn't familiar with initially when I started in hospice care. And so give us some examples. I know DNR, so DNR status is an example of goals of care. What other things would be examples of goals of laying out your
Sure.
goals?
Determining what is important to you, and it changes depending on how your illness is progressing. What may be something that you consider to be part of your treatment regime may change once your symptoms or your disease progress increase. So you may change what your goals are. So maybe, like you said, a DNR may be in place, which is the do not resuscitate. But a big thing is having a discussion with your family or friends and actually appointing someone to be your speaking person if you're in a position where you're no longer able to speak. That's called a healthcare power of attorney. So that's a big thing with goals of care. Another thing is presenting questions for that family to take back to their physician, because maybe once a patient has a better understanding of how their illness is progressing, they may decide they don't want to continue further treatment. So a lot of things can come into play with these goals of care discussions when the patients never had that ability to reflect. You know, when you enter a hospital setting, typically you're there for treatment and you're there with a problem, whether it's your congestive heart failures become worse or you have a surgical procedure, you're there for treatment. You never really have thought about where your illness is going. So these goals of care discussions allow the patient to reflect on what they want to do. And one of the things that we do with these goals of care is also talk about advanced care planning, which we'll get to in a second. But the wonderful thing with having these discussions early, when you identify the person that can speak for you, that person knows they're honoring your wishes, that they're not making decisions on their own. And what a great gift that is for your caregivers to know that they're following the patient's wishes and not guessing what the patient wants.
Excellent. Thank you.
Absolutely.
Okay, let me change to the next slide. There we go.
So as I said,
There we go.
advanced care planning. And as you know, in healthcare, like the military, we're very good with acronyms. So you may see the word ACP in documentation and in notes, and that means advanced care planning. And it's such an important thing that we do. Anyone over the age of 18 really should have an advanced care plan in place because one never knows what can happen. And if you're not able to speak for yourself, your family certainly needs to know what your wishes are. My role in hospice a few years ago was in the hospital setting where I met with patients and families once a hospice referral was made. And many times the patient's disease progress was so advanced, they were either too confused or unresponsive and unable to even participate in the conversation. So it was the family making the decision about either pursuing hospice care or not pursuing hospice and going on with treatment. And these poor family members, I knew leaving these meetings that conversations had never taken place prior to this. And this poor spouse or daughter or whomever was guessing and making the best decision that he or she could make. And I knew that, 9 times out of 10, there was going to be guilt involved. Did I do too much? Did I not do enough? And had these conversations taken place, there wouldn't be any guessing, and the family would know they weren't making this decision. The patient was making the decision, and they were just carrying it out and helping. So
Yeah.
these advanced care plannings are so important. And again, we get to this place by allowing the patient to reflect on their goals and values and understanding what possible future situations may pop up and what they would like or not like to do. And then some of those documents that Lori had talked about earlier that come into play with goals of care and advanced care planning are, living wills, health care, power of attorneys, one's code status. And a great thing in our area, nurses sometimes don't think it's great, but it is great. The charting and Epic is something that's used in our healthcare system here in the greater Cincinnati area in almost every hospital setting. So when these conversations take place, there is a tab in the Epic medical record that team members can see whether it's in the hospital, whether it's in a physician's office, whether it's palliative care, hospice. So you know where the discussions started and where they are currently and what the family's wishes are. So you're not reinventing the wheel. You know what things have been discussed previously. And it's very fluid. 6 months ago or 6 years ago, a person had in their mind what they wanted to do. And maybe it was aggressive therapy, which, makes total sense for a young, healthy person. But when disease happens, obviously, as it progresses, one's feelings for treatment may change. So living wills are constantly being updated, as they should be, depending on one's life experience. And healthcare powers of attorney can change. I know most patients would not, or most individuals would not want their ex-husband making their healthcare decisions. So we need to make sure that people have their healthcare power of attorneys updated because relationships change. And maybe the person they picked as their healthcare power of attorney 10 years ago is either no longer in their life or maybe even passed away themselves. So that is certainly a document that you want to make sure is current and not hidden, not put in a safety deposit box at the bank. Your healthcare power of attorney and living will need to be accessible. And the best thing to do is to have it scanned into your chart or your My Chart or your Epic system so everyone can see it. And with our hospice patients with that DNR status, a lot of times we have that on a magnet on the fridge. So ambulances that may come into the home have access to that DNR record.
Excellent. Thank you.
Absolutely. Benefits of palliative care. A lot of times it helps set the patient to meet their goals, and it actually allows for longer lengths of stay in hospice because many times the palliative care nurse that may be coming out to the home on a monthly basis recognizes the decline in the patient's status and may in fact make a hospice referral more timely than happens in the general population. Obviously, it decreases healthcare cost, although that's not important to this group, but it's still important because maybe we're avoiding unnecessary, uncomfortable treatments. Certainly fewer emergency room and hospitalizations. And obviously, it increases the quality of life because symptoms are being managed.
Right. Well, and just having that 24/7 support to be able to call in the night
Absolutely.
and to say, is this something that can wait till the next day? Is this something that I can get a prescription immediately to address? Or is this something I need to go to the ED? Like that can cause a lot of healthcare costs to the whole system, which raises
Right.
all of our premiums. So just avoiding those unnecessary costs actually does help us all on our pocketbooks. So
You're right.
excellent.
And as we're approaching the pulmonary season, if we can avoid going to the hospital or the ER, everybody wins.
Yeah, exactly. Yeah.
And then we're going to transition to hospice. Again, palliative care frequently can make the next steps to refer to hospice. As patients enter the end stage of their disease, the practitioners that are coming in can make a referral to hospice. And again, the acronyms, APRN is Advanced Practice Registered Nurse, which is what the palliative care practitioners are. Okay, we're going to transition to hospice now. What is hospice? And I am sure that many of you working as volunteers um, have been asked by your friends and family, is hospice a place? Because many people think it's just a place. And obviously, we have inpatient settings, which are very important to what we do. But hospice really is a philosophy of care. It's not a place. And hospice is appropriate for those patients with an estimated 6 month or less life expectancy. Patients must meet criteria and able to enroll in hospice care. And that criteria is that 6 month or less life expectancy and pursuing comfort care only, that one's not pursuing curative treatment. Hospice is covered 100% by Medicare Part A, Medicaid, and through most private insurances. And along with being a wonderful service with symptom management, it provides so many things. It covers the nursing visits, the medications, the medical equipment related to their illness, possibly some PT and OT for strengthening and safety, medical supplies related to the terminal illness, and it actually provides the whole team. And we'll get to that slide in a second, but it's a whole team approach that helps with the physical, emotional, and psychosocial symptoms that occur at end of life. Because we all know that pain is not just physical, there is certainly an emotional component to pain. And the volunteer department is an integral part of helping with the emotional pain that a lot of our families and patients deal with. The whole team, patient and family, obviously, are the center of what we do. But then we have our volunteers, obviously, our physicians, the spiritual care team, social workers, grief counselors, our home health aides and the pharmacist and the nurses and the nurse practitioners. That makes up the hospice team. In that volunteer department, it's not, I know there's a whole different layer. Lori, there needs to be an extra slide that has all the parts of
All the
what
extra, yeah, all the
volunteers,
extra layers
there needs
of
to be
things that
little, yeah,
happen.
that's
Yeah.
what volunteers do. But that's the whole part of the hospice team. So that's why it's such an important part of caring for the patient, not just physically, but certainly emotionally, which is a big thing that our patients deal with. The goal of hospice care is symptom care for comfort, not to cure. We're working on relieving emotional, psychosocial, spiritual, and physical suffering, and we're certainly promoting patient and family dignity. Okay. When's it time for hospice? When someone's been diagnosed with a life-limiting illness, and it's not just cancer, and that is certainly a myth that is out there that hospice is just for cancer. It is for any life-limiting illness. And these are just some examples. This is not the whole list, but there's end-stage heart disease, lung disease, kidney disease, cancers, dementia, ALS, strokes, neurological disorders, just to name a few. The life expectancy is 6 months or less if the disease follows its natural course, and that is certified by two physicians. The physician making the hospice referral, as well as the hospice physician. They both have to agree that there's a prognosis of 6 months or less if the disease isn't treated. And the patient and or family have agreed that aggressive procedures or treatments to cure the disease are no longer an option or desired. And Lori brought up a question to me earlier before we started. What happens when patients improve? Because sometimes that does happen. Unfortunately, it doesn't happen a lot, but it does happen. And internally, we call that people graduating from hospice. So we reevaluate patients every benefit period. The first benefit periods are 90 days. And then after that, we reevaluate people every 60 days. And as long as they continue to exhibit a decline, they remain on hospice. So if they're on service for a year or two, again, that's not the norm, but that can happen. We do not discharge patients if they continue to exhibit a decline and show to be hospice appropriate. However, if they do demonstrate an improvement, we do have to discharge them under Medicare guidelines. It really is Medicare fraud to keep somebody on service if they're not hospice appropriate. And when that comes into play, we certainly work to make sure they're just not left. We either get them referred to a home care agency. We certainly work with their physician to make sure that the doctors are aware and that they're set up to be successful. And that if we have to remove medical equipment, that new medical equipment under their home health or whomever it is taking over their care can get the right medical equipment in play. And then maybe in a few months or a couple of years, we can certainly reevaluate for hospice care.
Yeah.
Does that
Yeah.
answer
And
that question, Lori?
yeah, I mean, I think that answers it quite well. And we see, I would just add that we see with some of those neurological conditions like dementia and ALS and, Parkinson's, that they may be at a very slower rate of decline and could and have a very individualized journey. So they could bump in and out of the program a couple times.
Sure.
And that's one of the beautiful things. If they enroll in our social connections or enroll in our palliative care program, they can continue to have benefit of their volunteer social visits. So actually volunteers can be the sticky factor that continue to remain with the patient to say, well, things have been changing. Maybe you should reconsider going back to hospice. And so, if the volunteer wants to continue to follow them, certainly that's the volunteer's choice. Um,
Thank you. That's a good point. And I didn't say that. Thank you. Palliative care may be an option as well if they graduate from hospice care. And they can certainly stay with the patient and then maybe refer at a later time when the patient is showing a decline. But those neurological diseases can be tricky.
Tricky. Yeah.
Yeah, yeah,
It's a crystal ball thing. We don't
yeah,
all have crystal balls. Yeah. There you
exactly.
go.
Some of the triggers for hospice care may be that the disease is progressing and is no longer curable, significant weight loss, frequent infections, those trips to the ED and to the hospital are increasing, decline in their cognitive abilities, their decline in the ability to perform their own activities of daily living, skin breakdown, and then those increased risk factors of you're seeing an increase in falls, which certainly are safety risk, aspiration issues with their eating and drinking, and abnormal labs. In our long-term care settings, a lot of times in nursing homes, it's the nurse aides and the activity staff that note that, for example, Mrs. Smith certainly is not herself. She's not eating very much. She's not getting out of bed. She's not going to bingo. And obviously her activity tolerance has decreased and maybe she is warranted to have a hospice evaluation if she's showing signs or symptoms of this. Those repeated trips to the emergency room certainly are triggers for hospice care. And the wonderful thing about hospice care is decreasing the need for that because their symptoms can be managed at home. And as Lori had mentioned, that 24/7 availability of calling the office, a nurse can go out to see them no matter when it is to address those symptoms.
Excellent. Yeah,
Okay.
very much so.
Hospice provides support for the family as well, educating on the disease process and what to look for, and certainly what to expect. The emotional and spiritual support. Many times when a patient is admitted to hospice care and they are told about the whole team, many of them will say, well, I don't want a social worker because the thought of a social worker frequently is they're going to look at my finances or take my kids away. And that is certainly not the role of the social worker in hospice. It is emotional and spiritual support, as well as potential community resources that the family may not even be aware of that they may be able to tap into. So again, it's the support for the whole family, and certainly help in crisis. And that bereavement support is a big thing that hospice provides, and I'll get to that in a few minutes. So hospice care begins once the patient, and there's the acronym, the healthcare power of attorney, signs consent forms. Once the physician agrees the patient is hospice appropriate, the patient or family signs consents, and the care can start. The hospice team coordinates the plan of care according to wherever the patient's at. So if they're in a home care setting, we work with the physician. If they're in a long-term care setting or an assisted living, we work with the staff there as well. And that includes ordering medical equipment, medications, and other services that are needed, which would be, the nurse aide, the volunteer department, whatever is needed to make up that hospice team. And they certainly utilize evidence-based guidelines for pain and symptom management. And that is in there because another myth is we medicate patients, give them morphine, and hasten death. And that is certainly something that hospice does not do. Medications are based on, again, evidence-based guidelines. And our tagline is we start low and go slow with pain medications. We certainly treat symptoms aggressively, but we don't start meds aggressively. A lot of times we will get patients transferred to our inpatient unit if a patient's in a pain crisis, so we can slowly and safely monitor the pain medications. That nursing team is available that 24 hours a day, 7 days a week on that calling into our on-call line, the support team, as well as arranging visits. And the nurse and the team base their visits on the patient needs. It's not a cookie cutter. It's not the nurse comes out once a week or once a month. They come out at least weekly, but more if that is needed for the patient's management of their symptoms.
Yeah, a question is regarding the medications. So in the home care environment, the the caregiver is giving the majority of the medications, correct? So,
Correct.
and how does that happen? Like, so I know with my dad, we gave it sublingually, right?
Correct. It depends on everything's individual. Many patients do take pills, but certainly there are medications for patients that have a harder time swallowing, especially the pain medicine and the anxiety medications. It is available in a very concentrated form in a liquid that can be absorbed under the tongue, and it's less than a teaspoon. So that's another myth that everything is IV with hospice. And typically that's not the case at all. Things can be done sublingually, and there's other routes to give medications. IV is certainly an option, but that's not our go-to. Giving things sublingually is a lot more comfortable, and the pain medication lasts a lot longer. But our team works with the family to educate them on pain medication administration. But
Right,
there's always that 24-hour a day support if the family needs help with administering meds or has questions. They call us, and if need be, we go out to help, continue education with the pain medicine. And many times when we sign a patient on, pain is not a prominent problem, hopefully. But we order something called a comfort pack, and there are pain medications that are in a package that is not opened yet, but they're there because, a problem's going to happen at 3 a.m. when a
right.
nurse isn't there. So the pain medicine's in the patient's home typically. So they can call our 24-hour caregiver, I'm sorry, our 24-hour support team, and we can then help the family either administer or go to the home and administer the meds and educate the family on that. And that may require several visits that week to
Mhm.
work with the family on administering it. And again, if pain is a big issue that we can't get under control, that's the beauty of our inpatient units where we can admit the patient to get that symptom under control and get them back home.
And then for the assisted living and the long-term care facilities, how is medication delivered then?
Thank you, that's a good question. In long-term care and in assisted living, their team is still doing the primary caregiving. Hospice comes in as an extra layer of support where the nurse sets up a visit frequency with the family and with the long-term care staff. They do work with the family, and we do provide education on pain management to the long-term care facilities and educate them on how to administer pain medications. If there is a pain crisis or pain's not being administered or the pain medication's not being administered as needed, we can do something called continuous care where we have caregivers at the bedside, hospice caregivers at the bedside for a couple of days or whatever is needed for that patient to get that pain under control and work with the staff on administering pain medication. But we do work with them, educating them on the need to administer the meds as ordered. And there's
Yeah,
something called PRN where we can get pain medicine outside the normal, every 4 hours or whatever the orders are. They can get additional pain meds or anxiety meds or whatever is needed to address their symptoms.
right. But as a controlled substance in the state of Ohio, those are managed by the facility. And
Correct.
so,
Thank
right,
you.
so we're advising them.
Correct.
And that's, yeah, very important.
And
Okay, go ahead.
that 24-hour support line is available for the nursing home staff as well. And they do call, fortunately, and I'm happy they do call our support team frequently with questions or needs. And if we can't answer them, then an on-call nurse does go out to the nursing home or assisted living to make sure the patient's getting their meds and getting their symptoms adjusted and treated.
Excellent. Thank you.
One of the
Okay.
great things that, oh, I'm sorry. Was there
No,
something? Okay,
no, you were gonna, I just went to the next slide.
you're ahead of me. That's good. With hospice care, typically medications and treatments are based on specific just comfort care needs only. I'm rambling here, sorry. Patient care needs are comfort care meds only. However, we do have disease-specific programs at Hospice of Cincinnati to treat three big diagnoses that we see frequently. And these medications sometimes are not typical medications that many hospice providers would be utilizing. For example, our cardiac care program, we do utilize medications and anticoagulants that maybe other hospice providers wouldn't allow. It's certified under the American Heart Association, and we can keep patients at home and comfortable and increase their quality of life based upon these medications that we're allowed to administer. Same with our lung program. There are certain medications and breathing treatments that we can do to keep patients comfortable that aren't typical with other hospice providers. In our dementia program, and I am going to rely upon Lori to expand on this as well, but we can certainly provide a lot of treatments, symptom management that other hospice providers aren't able to do with our disease-specific programs because of the specialized training we give our staff. And again, you're going to see the acronyms with this as well. Our cardiac program is the ACCP. Our lung program is the ALCP. And our dementia program is the ADCP. So again, these programs have specific algorithms and treatments that we can use to manage those symptoms and prevent ER trips and hospital visits.
So, yeah, very specialized.
Absolutely.
Excellent one. Yep. So I think that was that slide too. Oh, is
Yeah,
there
definitely.
anything we missed? Okay.
That middle one that talks about the continuation of medications that may have been considered aggressive under some hospices, we can certainly do that with our cardiac program. And those disease programs have program coordinators as well to make sure we keep these patients comfortable and keep them at home. And for example, with our cardiac program, we weigh patients on a daily basis so we can monitor if they're gaining fluid weight. And that is a huge indicator of impending increased shortness of breath and other issues, but we can get those symptoms taken care of right away and again, prevent them going to the hospital.
Yeah, yeah. So an interesting fact about the advanced dementia care program is that about 50% of our patients have either a primary or secondary diagnosis of dementia. And when we started the program, just the concept of identification was a little bit, I would say, undercover. We would look for like a primary diagnosis like cancer or heart disease, and we may miss actually capturing that the person could also have early dementia. And so looking at it more holistically by these disease processes to say, have we looked at everything? Have we looked at the total picture of care, not just what is their qualifying diagnosis? And went from, I think we had about 11% in our medical records of people flagged with a dementia diagnosis when we started the program, and now we're up over close to 50% just by bringing prominence and recognition to the idea of the secondary diagnosis of dementia. So very interesting.
Thank you for that, Lori. And one of the other great things with the dementia program is how they do assessments on the caregiver as well, because there are certainly caregiver burnout with that illness, and paying special attention to the caregiver certainly helps the whole family.
Yeah, absolutely. Thank you. Okay.
And then bereavement is a big thing with hospice care. As we mentioned earlier, Medicare states the guidelines that a hospice has to follow, and bereavement care is one of the mandatory things that hospice provides. And every individual hospice in the area takes that and does what their program can do. Sometimes it's just mailings under some hospices. And I'm not criticizing that. That's the best that they're able to do. Our team, it's its own building. We have a whole wonderful inclusive bereavement care. We do calls and letters, but we also are able to identify high-risk family members. And sometimes that identification comes from the patient care team, where the social worker, the chaplain, the volunteers are aware that the family is going to be struggling. They're struggling now, and they're certainly going to be struggling when the patient passes away. So being able to identify that and knowing that bereavement care is going to be so important for that family. Our grief counselors do provide one-on-one grief services to our families for at least 13 months. And if it goes beyond 13 months, our grief counselors can work in getting them referred to somebody in the community. But we also have strong support groups for adults and great support groups for adolescent children as well. And that's through Fernside, which is also one of our bereavement wonderful programs that we have. And they do so much work with children through not just counseling, but a lot of art therapy. And the memorial services are a big thing that we do with bereavement as well. And it's not just with our family members, which is a big part of it, but we reach out to our community partners in our ALs, our assisted livings, and our nursing homes. Some of those patients have been residents in these facilities for years. So the loss of that patient is a loss to those caregivers. So providing memorial services in the community is a big thing that we do as well.
Yeah. And volunteers can also access grief counselors.
Absolutely.
So
Absolutely.
we know that sometimes when you've had a long time patient, that relationship has developed and that they become family in a lot of ways. And so you can be supported with that, either attending a group or one-on-one counseling. You would just reach out to me for those additional supports.
And our bereavement team does a lot of community outreach, and a couple of our counselors are involved in community support groups for people, for example, that have lost a loved one to a violent crime or substance abuse. There's all kinds of support groups out there. So if you ever have any questions, please contact someone in our Goldstein Grief Center that may be able to put you in the direction of a support group or a
Yeah, and
resource.
we do have also, we are doing, we got a grant to do some more community building awareness on grief. So if you have a group, workplace, something like that that you think could benefit from a community outreach education on grief, we would appreciate you just reaching out and partnering with us on that, a faith community or anything. Um, and so with that, we're kind of at the end of the presentation, but I want to make sure we have an opportunity for questions. So I am going to, for a minute here, just allow anybody that would like to can raise their hands or uh, do, any type of reaction that you would like to be able to ask a question. Anybody? Anything? Okay. Or any chat questions that you might have overall. Um, I will say a couple questions that we have gotten in the past that I think Carol may be able to speak to is, so clearly these are all volunteers who are passionate about making sure that everybody gets the end of life care that they need.
Sure.
We encounter friends and families who are not as comfortable with the end of life as we may be. And so it's always like, how can we broach the subject of hospice can help, or palliative care can help with someone. What's a good way to introduce that conversation or to get started that people may be receptive to?
Yeah, depending on their relationship, and I'm gonna guess it would be a friend. So I think some deeper diving to ask, for example, how's your mother doing? Have you seen any changes? Have you talked to your physician about how she's doing? maybe palliative care or hospice could be a wonderful extra layer of support for her and your family. Uh,
Yeah, I had Dr. Mini Shrivastava, who is our medical director. I actually ran into this situation with my mother-in-law. She lived in California at the time. And my sister-in-law was her primary caregiver and was reluctant, to use the hospice word. And so Dr. Shavastava said to me, just in the hospital, just ask for a palliative
palliative
care
care, yeah.
consultation. A palliative care consultation sounds very different than you need to go talk to hospice, right?
You're right. And maybe that's the building bridge. You're right. And then the nurse, as we talked about palliative care, the nurse comes out a couple of times or more,
Yeah,
and the relationship and the trust develop, and the palliative care nurse can then ease into that conversation about hospice care if that's appropriate.
yeah,
That's a great
yeah.
example.
Yeah,
It
so
all
asking
depends
for
on your
palliative care consult, and that's part of the reason why we changed our name to HOC Navigators, not just because we do more than just hospice, but HOC Navigators tends to be a little less threatening with the big hospice word. And so they can do that. So with a palliative care consult, how would somebody get started with that for
there
us?
there needs to be a physician referral.
Okay.
So they would, if they're in a hospital setting, that's easy. The hospital physician can make the referral. If they're in a home care setting, they could call our office, and our office could call the physician and request an order.
Yeah.
But there has to be a physician order. But that does happen where they'll call our 891-7700 phone number, ask for palliative care, and then say they're interested in getting this set up for for example, their mother. And
Hmm.
then our office could call the physician's office and see if the physician's in agreement that this would be an appropriate referral.
Right.
And I would say more than half the time, the physician in the field is going to want the extra layer of care for
Right.
for their patients.
Yeah. And so they call the number, they would, we would contact the doctor to get a referral. And then HOC would do what? We would schedule an appointment or what?
Correct. They call the patient or family and arrange a time that works for the patient or family. And then the nurse practitioner goes out to the home and admits the patient to palliative care if that's what everybody wants. She does an
Mhm.
assessment and determines the patient is in fact appropriate for symptom management. Because
Mhm.
typically that's what it is with palliative care, that you're working on managing a symptom. And the patient can still continue their treatment with palliative care,
Mhm.
whether it's chemotherapy or radiation or whatever they're pursuing treatment wise.
Mhm.
And palliative care comes in as an extra layer of care. And then again, as that practitioner develops a rapport with that family and can document a decline and educate the family on that,
Yeah.
it's an easier progression. And then
Yeah.
he or she then can make the referral to hospice care if the patient and family are in agreement.
Yeah. Yeah. Excellent. Great. And then HOC would, so we would share based on the assessment, if we thought that somebody was maybe could qualify for hospice, which is a higher level benefit. You get more services that are covered. And so,
Absolutely.
but of course, it's the person who gets to decide. So we have a couple
Right.
questions. First of which is from Belinda. She is asking if a volunteer is a licensed ordained minister, what are the limitations in assisting the patient or family members during end of life? So, Belinda, our spiritual care volunteers, they operate in the same role, whether they are licensed or unlicensed as ordained ministers. So we only have two roles within Hospice of Cincinnati. We have spiritual care volunteers, and then we have our chaplains. And so our chaplains are going to deal with anyone that is experiencing spiritual distress, and helping to document on their emotional, and that's a requirement by Joint Commission. So a chaplain may visit, for instance, once a month or more frequently if there is spiritual distress existing. Where a spiritual care volunteer would partner with the chaplain is perhaps in offering additional visiting, praying, playing music, reading prayers, things like that. And they would work together to increase the amount of spiritual supports that are provided. But the roles are not different because somebody is licensed. It's just spiritual care volunteer and then a chaplain within HOC. So, the other question, do you refer private doulas for grief support in the case the patient was not enrolled as hospice, such as a violent death? We do not refer, we still refer to the Goldstein Grief Center is open for community support. So it really does not have, the manner of death is not a requirement. It is a separately funded, not-for-profit that's just also co-managed by Hospice of Cincinnati. So we do have people actually that have gone through other hospices, that never went through hospice at all, that are part of sudden death, loss, car accidents, and things like that, that do access the Goldstein Grief Center for both group and individual support. So we don't refer out to doulas because we have that resource internally that we would refer to for first. Now, if the grief center, after the person has been a part of our program and wants to suggest they continue, I'm sure that they have resources that they continue to offer as a part of that. Okay, other questions? Thank you, and thank you for letting me know that. Awesome, thank you. So, questions? Any additional questions? We have. I think we're right at about time. We've got about 4 minutes left. So I'm just going to thank you, Carol, and thank everyone for participating, and appreciate people letting us know. So one of the things that I think is always an interesting question is the measuring stick for declining. I think is always a question mark. Like sometimes I hear people saying, oh, they're declining, they're ready, they're going to pass soon. And I sometimes see them and I'm like, well, okay, they're still eating, they're still walking around, they're still carrying on regular communications and things like that. To me, that doesn't seem to be as close to passing as others are. So what would you say is the decline level that we're looking for somebody to be enrolled in hospice care? Like, are they still toileting themselves? Are they, what kind of things do we look at?
It's really disease specific.
Mm-hmm,
With something like end-stage dementia, if they're still ambulatory and doing their own activities of daily living, that could go on for a couple of years.
mm-hmm,
So that may not be appropriate for hospice. I'm not saying that it's not. Everything is
mm-hmm.
individual. Uh,
Yeah,
with a cancer diagnosis, for example, that's not being treated, there really would not need to be the decrease in the activities of daily living or,
right,
not, it's just the disease process itself is going to continue to decline just because they're not seeking treatment for that cancer diagnosis that they have. So
right.
triggers, I'd mentioned the triggers with the weight loss. They
Mm-hmm.
look at maybe a 10% weight loss as an
10% way, okay.
indication for hospice appropriateness with most every disease process. the frequent hospitalizations, the frequent ER trips, the decreased tolerance of activities. It really depends on what their disease is. Dementia has its own set of criteria for admission to hospice, and it's the weight loss, bed bound, skin breakdown. It would really have to be a nurse assessing the patient. But weight loss is a big one across the board with diagnoses. But if there are multiple systems involved, if the patient has dementia, but isn't totally on board with some of the signs and symptoms of hospice eligibility, but they also have a comorbid, additional diagnosis of, heart failure or respiratory distress issues, they may certainly be hospice appropriate. It really would determine the assessment and what the physician also feels.
Excellent, excellent. So, and so looking at things like weight loss, looking at things like decreased function, but then for those diseases like cancer, we know that somebody going without treatment, it's a shorter course of time. So
Correct.
yeah.
Especially if it's metastatic and there's multiple sites.
Yeah.
It's a much easier, I don't want to say easier, they do not have to have all of the issues that you would have to have with an end-stage dementia diagnosis.
Right. Things like coming off of dialysis, that has a real clear trajectory.
Yeah, correct.
Yeah. One of the questions I get sometimes is about tube feeding. Do people have to stop tube feeding to be able to enroll in hospice care?
They do not, as
Yeah.
long as the tube feeding isn't causing harm.
Yeah.
And again, and those are conversations that we have as the patient admits to us, and we never stop nutrition as long as a patient is tolerating it. But many times as a disease progresses, that can be a hindrance. There's aspiration issues, pneumonia issues, diarrhea, constipation, nausea, vomiting. It depends on how the patient's tolerating it.
Tolerating it. Excellent.
But definitely we would not stop it if another myth. We do not stop that if they're tolerating it.
Excellent. Okay, well, thank you so much, Carol. And I see Belinda is still typing, so I'm going to let her finish her typing and see what I can answer for her question. And then we will go ahead. Okay. This has been a wealth of good communication. Thank you, Belinda. Well, that is a good time to end. So thank you. Everyone have a wonderful afternoon, and don't hesitate to reach out to Carol or myself if you have any need for further clarification or referrals. Everyone deserves the benefit of hospice and advanced illness care. Hospice HOC Navigators does it the best in the city, and we want to be a way to get people the care that they need. So thank you. All right, take care. Bye-bye.
Bye. Thank you, guys.